Um, I I think my talk is actually a nice transition from Professor Christakis's talk, in that I'm going to provide a perspective on how New York City and the phenomenon of the COVID-19 pandemic reflected some of the deep and historic social inequities, and how environmental factors both drove those inequities even further in the context of the pandemic, and themselves may have been contributors to the severity of the disease itself. Um, but first, I'm just going to provide a background of the context in many urban centers, urban cities in the United States, and in some ways across the world, in that before the COVID-19 pandemic, in the United States at least, we had substantial disparities, substantial social inequities, such as but cut across race, ethnicity, as well as immigrant status. We have substantial inequalities in income, job placement, food security, and we have also substantial disparities already in chemical exposures, as well as capacity to protect oneself from the pandemic, from the viral exposures themselves, as well as a lack of access to the digital sphere, which is increasingly important in this modern world. During the pandemic, these inequities were even laid more bare as a serious series of consequences. An inability to find jobs or to keep jobs was even more substantial for companies that were less well able, for families that were less well able to bear with that. Food insecurity was magnified. We had increased consumption of foods known to be contaminated with synthetic chemicals that can exacerbate immune dysfunction. We have substantial increases in social stress. And we had, particularly in children, as a pediatrician, this is quite concerning. We had these populations falling further behind academically, not to mention, in many cases, losing family members due to COVID-19 or having disability due to COVID-19. This slide presents some of the many interacting factors that contribute in a unfortunate circle, magnifying as you move around the circle, ultimately to SARS-CoV-2 infection spread and severity. The shelter-in-place orders certainly magnified social phenomenon that I've already described in the previous slide, and I'll get to that a bit later. On the right, you see disparities in chemical exposure that indirectly can contribute to immune disruption. And we have disparities in air pollution and other environmental exposures that contribute to chronic diseases, which are risk factors themselves for ultimately infection severity dependent upon being exposed to SARS-CoV-2 itself. I'm going to begin by focusing on the phenomenon that magnified exposure in populations, in communities of color and low-income populations. As depicted here in these slides, there were many limitations on the access to PPE. We had workplaces with an inability to have ventilation, and therefore there were longer time periods in which workers were exposed to infection. And that and it was well known early on in the pandemic that there were certain super spreader events that affected not just meat warehouses, but workplaces where there's a high density of people by nature of the job. We also so that was one way in which early on in the pandemic we saw emergence in greater exposure to SARS-CoV-2 in low-income populations and immigrant populations. We also have noted for many years disparities in air pollution and other environmental exposures that themselves contribute to chronic disease that can magnify the infection severity given SARS-CoV-2 infection. We know, for example, that air pollution in the United States does not continuously distribute in a clear way across the U.S. population. We know that African American populations have much greater exposures to fine particulate matter, and that has already been associated before the pandemic with increases in lost lifespan due to those exposures. We also know that synthetic chemical exposures are disproportionate in low-income communities and communities of color. These include the non-stick chemicals, the bisphenols used in aluminum can linings and thermal paper receipts, and phthalates used in personal care products, cosmetics, and food packaging. We also know that air pollution is a mediator of COVID-associated chronic disease. We know that air pollution is associated with an increase in mortality early on in the pandemic in relationship to levels of fine particulate matter. We know that air pollution contributes to comorbidities that may likely explain this increased morbidity. These morbidities include diabetes, cardiovascular disease, asthma, and obesity, 4 key COVID risk factors. And the racial and ethnic disparities in these COVID-19 risks were already well described before the pandemic. So this sets one up for the perfect storm in magnifying disparities by income and race and ethnicity. Synthetic chemicals are also known to contribute to obesity, diabetes, and cardiovascular risks, as described in multiple epidemiologic studies depicted here. So we have, unfortunately, the perfect recipe for magnifying disparities in COVID outcomes independent of the frequency of COVID infection itself. We also know, and this is an emerging scientific literature, that synthetic chemical exposures can contribute to immune disruption. We know that particulate matter has long been known to be an immune modulator, disrupting how the body responds to pathogen-associated molecules, particularly triggering the release of cytokines and chemokines. We know about the cytokine storm that was early and evident in patients with SARS-CoV-2 infection who had severe sequelae. We know that ozone disrupts epithelial integrity. And we know that the perfluoroalkyl substances, even in one study, have been associated with more severe COVID-19 infections, so that needs to be verified in other studies. We had already known that PFAS exposure is associated with decreased immune responses and increases in infections in children, more ranging from colds to stomach bugs, but speaking to plausibility of the phenomenon by which other synthetic chemicals can disrupt immune function and thereby increase susceptibility to COVID-19 infection and ultimately illness. Now, it's not lost on me that this is in the context of a broader milieu of social determinants of health that set up low-income communities of color for worse COVID-19 outcomes. And I'm just going to elaborate on a few of these here. We know that psychological stress can have a broad array of effects across the lifespan. These range from prematurity, reduced lung function, increases in adiposity, as well as other neuropsychological sequelae. And we know that epigenetic mechanisms for these sequelae have been described. So suffice it to say that psychological stress is likely to be a substantial mediator of long-term adverse health outcomes, especially in children who lived during the pandemic in Generation C. We also know that the pandemic made it more difficult for some families to obtain healthy food options. This was exacerbated by public school closures in New York City, especially. School lunches are actually a major source of the diet, particularly of low-income populations. And physical inactivity was exacerbated by the shelter-in-place orders and lack of access to physical education time in school. And we know that sleep disruption can magnify the effects of stress, thereby increasing risk for obesity. When I was introduced, it was alluded to that I participated in a large National Institutes of Health consortium that had preceded the pandemic called the Environmental Influences on Child Health Outcomes Program, or ECHO. We're a large consortium of cohorts nationally that was actually well poised to have pre-pandemic data about children's health and then longitudinally follow populations of children in real time to see what the adverse sequelae are. These represent some modest early data from the pandemic, which confirm the increases in hours of screen time in 325 children with longitudinal data. What's striking about these data, even though the sample is relatively small and needs corroboration, is that in bold, you can see the disparities in the change in screen time duration being concentrated in Black and Hispanic populations. And that reinforces the point that I raised earlier, that low-income communities and communities of color have disproportionate impacts of the pandemic in multiple modes. We also know that in an increasingly digital world, especially increasingly digital pandemic world, that low-income communities don't have the same access to broadband, which was the basis for childhood education for many months in the pandemic, which is why in New York City and other parts of the world, you've seen vigorous debates about getting children back to school, because some populations of children simply would otherwise not be able to attend school, widening educational disparities. We know in particular from early experiences in the pandemic that undocumented immigrants, a substantial population in the United States, 5 million US-born children, were especially vulnerable. This was in part due to the political dynamic at the time and the resistance to immigration policy at the time. And there were dire conditions in immigration detention centers. Now, I've been able to work with colleagues to describe some more of the aspects of the COVID-19 pandemic and its implications for New York City mothers and families. In this data, we were able to describe, this is based on responses to questionnaires, mostly during the first wave of the pandemic, but you can see in the lower bullets, approximately 5% of the population met WHO criteria. Testing was not widely available at the time, so that's higher than the percent that were told by a healthcare provider that they might have COVID-19 or tested positive. But the last bullet is important because it reinforces some of these social determinants I've talked about that magnify the risk of infection for COVID-19, that is living in proximity to an essential worker or having a job that put them at high risk of COVID-19. COVID-19 also had consequences for pregnancy intention and fertility. On the left, you see a subpopulation of our birth cohort of mothers who were thinking about becoming pregnant, and you can see a substantial reduction during the pandemic in likelihood of trying to become pregnant or thinking about becoming pregnant. In the population that was actively trying to become pregnant at the time of the pandemic, nearly half the sample stopped, and many were not sure if they were going to resume trying at the time. And many, the vast majority of those who weren't thinking about becoming pregnant stayed so. And when we looked at specific drivers of the reduced intention to conceive, financial insecurity emerged as a substantial driver. Even though these odds ratios do not reach the conventional statistical significance, the directionality and trend is suggestive. Now, I'm going to revisit, as I wrap up, ways we can reduce the effects of the pandemic in populations who most need it. And I'm going to suggest focusing on psychological stress, food insecurity, and the digital divide as 3 areas of focus. So again, going back to our large ECHO-based consortium, we were able to look collectively at factors in the family that can reduce the relationship on the left between COVID-19 acute stress in children and reductions in child satisfaction. And ultimately, we saw that family engagement and child social connectedness appeared to mitigate the effects of acute stress in children on life satisfaction, suggesting that healthcare providers, educational settings, social workers can overall support family engagement as a pathway to mitigate the social effects of the pandemic in particular. We also need to work even harder in the United States on addressing food insecurity. There are multiple steps that we need to take to adapt our environment. We've mostly thought that food insecurity was a bygone phenomenon, but the reality is that we need to work even harder in populations that are most vulnerable, especially during future pandemics and future crises, so that we can improve children's health. Finally, the digital divide is a severe problem. On the right, you see a map of the way communities were divided into lending support through a practice known as redlining, which historically put populations of color and low-income communities in a situation where they were divided in where they could live based on their accessibility to low interest loans. And the patterns you're seeing on the right in that image with digital redlining, with redlining, if you will, are similar to some of the issues we face today with a digital redlining phenomenon. And we need to, in particular in the United States, target funding to support technology access as a pathway to improve educational outcomes, as well as access to other opportunities for families. The reality here is that COVID-19 was a disruptive event that will magnify the need for digital access in society. So I'll close with a final comment that, in particular in the United States, the COVID-19 pandemic was a disruptive event, but we also had other disruptive events that emerged at the same time. In many ways, there was the perfect storm to address overdue, I must emphasize, racism as an underlying phenomenon behind much of these social disparities that we've described. And while we have not fully addressed racism as a challenge in American society today, I would argue that addressing racism is a pathway to reducing disparities in anticipation of future pandemics, and also for the betterment of children's health.